Hello everyone, we are Group 1K, and today we'll be presenting the analysis of Finland's tax-funded healthcare system. And this presentation aims to assess the performance, goals, financial system, and organizational model while identifying key challenges and ultimately providing recommendations to enhance Finland's current system to achieve high quality and a more equitable healthcare system in the future. Firstly, I will delve into Finland's performance and goals. Here we take the UK and Greece, which are also tax-funded, and Germany, one of the most established social insurance-based system, as the neighboring peers to evaluate Finland's performance. And in terms of the mortality measures, Finland has demonstrated robust data with the highest life expectancy across the analyzed countries. Regarding healthcare spending, Finland is considered efficient with a relatively low current health expenditure out of the GDP and a moderate out-of-pocket spending. While the system faces challenges of regional inequalities as shown by the density of physicians. Finnish residents in rural areas experience longer waiting times and a delayed access to primary care due to physician shortages in smaller municipalities, normally extending to 6 to 8 months. And grounded by the GROW model interpreting the current situation, the government proposed a health in all policies approach, which encourages cross-sectoral collaborations for efficient resource utilization. And accompanied by social and healthcare reform, it aims to centralize the fragmented municipal system into larger, regionally governed entities, eventually addressing disparities in service quality and demographic pressures. Doing so can resolve potential issues regarding effectiveness and equity as intermediate goals. As for the long-term goals, the government will continuously focus on improving patient satisfaction and finally adopt a more equitable model to raise the population's health outcomes.
For demographic factor, the aging population and declining workforce will continue to increase healthcare demands and strain resources over decades. These trends deeply influence service delivery and financial sustainability. Economic factor is placed there as economic stagnation combined with rising healthcare costs due to chronic diseases and aging, poses ongoing challenges to the sustainability of healthcare financing. Epidemiological is positioned here as 40% increase in mortality and emergency of H5N1 require immediate action, such as vaccination programs, while their border effects may taper off in the medium term. For technological, the data breach highlighted urgent cybersecurity gaps requiring immediate action to restore trust and safeguard patient information. Investments in telemedicine are reducing rural-urban disparities and improving efficiency, particularly in chronic diseases management. While these advancements addressing pressing needs, their full impact will take time to materialize, aligning with the medium-term horizon. Please see the slides for the explanation for the rest of the factors.
Before 2023, Finland's healthcare system operated with significant local autonomy. The central government's weak role combined with multiple financial flows and 3 overlapping service provision channels resulted in weak stewardship and inefficient cost containment. To address these issues, since January 2023, primary and specialist care and social services have been reorganized into 21 well-being service counties, WBSCs, are funded through the state budget and governed by elected councils, reducing reliance on municipal taxes and addressing regional funding disparities. This reform established a centralized tax-based funding mechanism, strengthening the public sector's role while private and third sector providers complement public services. Revenue collection, purchasing, and service provision follows a mosaic model with diverse revenue sources including state and municipal taxes, insurance contributions, and out-of-pocket payments. Purchasing remains decentralized, involving public and private providers, with WBSCs implementing performance-based contracts. Service provision is similarly varied as multiple organizations supplement public health care. Vertical integration is evident in specialized care delivered by hospital districts, municipalities, or private providers commissioned by these entities. To the right is a summarized diagram showing the organization and financial flow in the healthcare system, highlighting a mixture of both public and private expenditure. Finland's health expenditure as a share of GDP accounts for 9.7%, which is 0.7% lower than the EU average. Around 75% of health expenditure comes from public government schemes, while the rest comes from private expenditure and voluntary schemes. The system is primarily financed through taxation, complemented by out-of-pocket payments and national health insurance contributions. These funds cover a wide range of services, including primary and secondary care and prescription drug subsidies. This balanced funding model ensures equitable access to essential services while maintaining maintaining fiscal sustainability with a greater focus on public funding to reduce the financial burden on individuals and show its commitment to universal healthcare. While the system is generally progressive, certain elements are regressive, creating disparities in how healthcare costs impact different income groups. Income taxes are progressive, meaning higher income individuals contribute a larger percentage of their income, ensuring equity in financing. For example, municipal taxes fund health services at the local level, and wealthier regions redistribute through state grants to poorer regions. Employers are also required to contribute. Subsidies reduce out-of-pocket payments, and KELA reimburses part of the outpatient medicines. For example, there's a higher reimbursement rate for essential and costly drugs. However, regressivity remains as there is still a high proportion of out-of-pocket payments compared to other private expenditures. Patients must pay co-payments for outpatient care, medicines, and dental care, which disproportionately burden low-income individuals. For example, elderly and those with chronic conditions suffer from high cumulative out-of-pocket payment costs. Moreover, voluntary health insurance is used to access faster private healthcare services, creating a two-tier system resulting in inequities between those who can and can't afford it. The Kakwani Index measures the progressivity or regressivity of a tax or healthcare financing system. Finland's Kakwani Index of 0.237 demonstrates a progressive system, meaning high-income individuals contribute a larger proportion of their income. This aligns with Finland's tax-funded universal healthcare model, ensuring access to essential services for all residents with minimal financial burden.
Regions in Finland are funded through statistical risk-adjusted models without the ability to collect taxes directly. They can collect user fees, but with a legislation cap, this limits the out-of-pocket payments. This model ensures equity and distribution according to need, but faces challenges in accounting for unique healthcare demands and requires complex frequent revisions. These pie charts here show the health expenditure by type of service and provider. The amount spent on outpatient care is double the amount spent on inpatient care, which can lead to insufficient hospital resources, longer wait times, and inadequate care for complex or severe conditions, whilst shifting the burden to outpatient services, which may not be equipped to handle advanced cases. Underfunding in patient care also contributes to healthcare inequalities and leaves systems unprepared for emergencies, potentially increasing long-term costs. Hospitals and ambulance services are major components of health spending. Regional inequalities can still arise, affecting service delivery and access across the whole country. As for provider payments, most physicians are salaried employees of municipalities, with pay typically not linked to performance indicators. A capitation model allocates resources based on population needs, promoting equity. Private physicians, however, including specialists, charge patients directly for services, but around 30% of these costs are then reimbursed by KELA, the national insurance company. This combined approach ensures accessibility while incorporating both public support and patient investment, aiming to balance equity, efficiency, and costs.
Finland's healthcare system excels in quality and universal coverage, funded by taxes and offering free services for children and pregnant women. It ensures equity and affordability, though rural areas face doctor shortages addressed through telemedicine and workforce incentives. Comprehensive services include checkups, specialist treatments, and long-term care with private insurance for faster access. Advanced technology supports chronic care, enhancing efficiency, while aging populations add pressure. Responsiveness is reflected in personalized, multi-channel access, with accessibility improving via remote care solutions.
Having explored Finland's healthcare system, here are some recommendations. With around 10.2% of foreign residents, language and cultural barriers can impact quality of care. Cultural competency training of healthcare workers and recruiting multilingual staff can improve communication, reduce disparities, and enhance patient satisfaction. Furthermore, awareness and accessibility of social services of marginalized groups like the elderly can pose challenges. Targeted outreach and educational campaigns prioritizing vulnerable populations, including immigrants and low-income households, can ensure they understand the available resources and how to access them, ensuring equity. As healthcare becomes more digitalized, safeguarding patient data is crucial. Incidents like the Vestimo data breach highlights the need for stronger cybersecurity infrastructure. Regular assessments, stricter policies, and staff training can help restore trust and security. Finally, to improve efficiency, Finland can adopt a tariff-based system similar to Finland's TAMT and Germany's tariffs. Linking payments to procedure complexity, tailoring its approach to local priorities, use regional adjustments to address these parties, and leverage e-health infrastructure for monitoring. This will promote transparency, reduce inefficiencies, and ensure equitable access, reinforcing Finland's universal healthcare goals. In conclusion, overall, Finland's healthcare system is good and strives for equity, but these further refinements will make it even better. Thank you for listening.